Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Systemic corticosteroids. These are classified based on their duration of action into three classes. One is short acting, which will act only for a period of 8 to 12 hours, which includes cortisone and hydrocortisone. 25 mg of cortisone is equivalent to 20 mg of hydrocortisone. Both these drugs have more mineralocorticoid side effects. Next, second class intermediate acting, which acts for 12 to 36 hours, which includes difluzacort, prednisolone, methylprednisolone, and triamcinolone. 6 mg of difluzacort is equivalent to 5 mg of pred, 4 mg of methylpred, and triamcinolone. Here only prednisolone have some mineralocorticoid effect. Rest of all the drugs have negligible mineralocorticoid effect. Next, last class, long acting, which acts for 36 to 72 hours. Both dexa and betamethasone, just 0.75 mg, which means less than 1 mg is equal to 6 mg of difluzacort, 5 mg of prednisolone, 4 mg of methylpred. If we want to shift from one drug to other drug without changing the potency of the drug, we can use this dosage equivalences and shift from one drug to another drug. Coming to pharmacology, as we know, steroids are highly lipophilic, hence they are well absorbed from gut. They can cross blood-brain barrier, placenta, and even found in breast milk. They are metabolized in liver to water-soluble inactive forms, which can be easily excreted via urine mainly, and a very little is also excreted via bile, that is through feces. Coming to drug interactions, whatever the drugs which enhances the metabolism by stimulating CYP3A4 enzyme in the liver will reduce the serum levels of steroids. Example, phenytoin, rifampin, barbiturates. Similarly, whatever drug which inhibits the metabolism of steroids, that is CYP3A4 inhibitors, obviously will elevate the levels of steroids in serum. Examples, azoles and macrolides. Whenever we are prescribing both steroid and azoles, anyway azoles elevates the levels of steroids, so we can adjust the dose by reducing steroid dose. Natural cortisol levels in our blood will be at its peak at 8 a.m. in early morning. So there will be maximum suppression of HPA axis, that is hypothalamo pituitary adrenal axis will be suppressed naturally at 8 a.m. in early morning. If we give steroids at this time, there will be very little suppression of this axis. So hence we will be prescribing always early morning dosages of steroids, except when our target is to suppress HPA axis. We will give at bedtime, when we will use this to suppress adrenal androgens. In some diseases, these androgens are the culprits, like in hirsutism and acne. I have posted one meme in my Instagram page also, that steroids are the reason for hirsutism and steroids are the treatment option for hirsutism. Coming to indications of systemic steroids, autoimmune diseases like pemphigus, bullous pemphigoid, linear IgA disease, connective tissue diseases like SLE, dermatomyositis, vasculitis, all erythrodermas except psoriatic erythroderma. If we give steroids in psoriasis, it may get converted to pustular psoriasis. Plaque psoriasis may get converted to pustular psoriasis. Immediately there will be reduction in the disease severity, but when we stop steroids, it may have flare-ups of psoriasis, which will lead to severing of the disease. Eczemas, severe eczemas, extensive alopecia areata, will give oral steroids. Lepra reactions, these lepra reactions are very important. Reactions are nothing but our own immunity. On the way to destroy lepra bacilli, it will even more destroy our own nerves, so we have to control that immunity. If we give steroids on time in lepra reaction patient, we can save the patient from permanent deformities and disabilities, as steroids will prevent deformities, disabilities, prevents nerve injury by our own immunity. Hence, it is very important to diagnose on time lepra reactions. Extensive widespread lichen planus, progressive vitiligo. If vitiligo is progressing very fast, we can give oral steroids. Sarcoidosis, sweets, pyoderma gangrenosum. In my part 1 video, I have asked one question where we can give steroids even on ulcerated skin, that is pyoderma gangrenosum. Here ulcer will be very severe, that even muscles and bones will be visible to our eyes, and in that situation we can give steroids, intralesional injections, topicals. It will respond well to steroids only. Hormonal disorders, hirsutism and acne, we have already seen. Here androgens are culprits, so to suppress androgens we'll give steroids at bedtime to have maximum HPA axis suppression. Capillary hemangiomas. Coming to adverse effects of corticosteroids, it is of two types. One is because of continuous usage of steroids. Another one is due to sudden stoppage of steroid without tapering. This will occur only when the patient has been taking steroids for more than 2 weeks. For just a short course of systemic steroids, no need to taper the dose, we can abruptly stop the dose. But once if the patient took steroids for more than 2 weeks, we have to always taper the dose to avoid withdrawal side effects. What are those withdrawal side effects? It may lead to withdrawal syndrome called glucocorticoid withdrawal syndrome. What happens if we stop suddenly? Patient may get lethargy, weight loss, malaise, myalgia, nausea, headache, fever, arthralgia. Patient may also get flare-ups of underlying disease. For what we have given steroids, that disease may pop up again with increased severity. Adrenal crisis, also known as acute adrenal insufficiency. Patient has been on our exogenous steroids more than 2 weeks. Endogenously, HPA axis have got suppressed. It is not producing any androgens or steroids from adrenal gland. Suddenly when we withdraw all the steroids from the body, no steroids will be left in the body. Until then, steroids will be holding on salt, increasing blood pressure, increasing glucose. Now suddenly every steroid has been withdrawn from the body. What happens? There will be sudden hypoglycemia, sudden fall in sodium level, sudden fall in BP, that is blood pressure. Even the patient may go into unconscious state also. This is an emergency situation. It may occur when you suddenly stop the drug without tapering. So always taper the dosage of steroids. Due to continuous usage, which it is directly related to dose, duration, frequency. If you give more dose, more number of times, more duration, side effects will be more. What are those side effects? GI side effects, mainly peptic ulcers, intestinal perforation, pancreatitis, mainly ulcers. For eye, cataracts and glaucoma. Cataracts, osteoporosis, these are all not dose dependent. Even with short course of duration also they may occur. Avascular necrosis, hypertension because of sodium and water retention. Hypokalemia because of mineralocorticoid effect. Mineralocorticoid effect will cause retention of tasty mineral salt and will eliminate potassium from the body, which leads to hypokalemia. Increased risk of atherosclerosis because of fat redistribution, hyperlipidemia. Endocrine side effects like growth retardation in children. Secondary amenorrhea. Metabolic effects like hyperglycemia, hyperlipidemia. Because of hyperlipidemia, there will be redistribution of fat, which leads to moon faces, full of fat over face, buffalo hump over back, and central obesity. Rest of all the body parts will doesn't have any fat. Only these areas will be having more and more fat. That is redistribution. Infections. Obviously, when you are suppressing immunity, opportunistic infection will come. Reactivation of TB, extensive dermatophytosis, psychiatric side effects like euphoria, hypomania with short course of steroids. If we are giving for a long term, patient may land in depression. Inhibition of fibroblasts will occur, which leads to delay in wound healing, thinning of skin, striae, mainly abdominal striae, which will be in purple in color, purple striae, ecchymosis, purpura, these may occur. Others like acneiform eruptions, which will be monomorphic, more on trunk, hypermelanosis and hypertrichosis. How to prevent all these adverse effects? What we can do? We have to first exclude whether the patient has TB, diabetes, hypertension. We should restrict sodium intake, as steroids already storing the sodium inside the body only. So we have to restrict sodium, and if we have to supplement potassium. Use proton pump inhibitors, H2 blockers, antacids to save patient from peptic ulcers. Supplements of calcium 1 to 1.5 grams per day, vitamin D 50,000 international units twice a week. Why patients are more prone to osteoporosis? To prevent this bone mineral resorption, we can also give bisphosphonates like oral alendronate 1 to 2 mg per kg once weekly. Coming to intralesional steroids, intralesional triamcinolone 0.03 mg per ml, very less dose, is given for alopecia areata. 10 mg per ml is given for prurigo nodularis, LSC, morphia. High dosages 40 mg per ml is given in keloids mainly and hypertrophic scars. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.